Hey, so I've been trying to put stuff together so that people can see these things at their leisure, or when I'm not here, or necessity. Maybe new people will see this stuff. I don't know, but if I'm not here in the future, you'll have something to reference because I do not have an infinite amount of time on this planet or in this unit. So we did the flow track, and that was great, but it doesn't give us everything. The next step really is the invasive monitoring, the hemodynamic monitor, which is the Swan. Uh, the Swan is, it gives us the most valuable information. It gives us the best information. People are scared of it because of the risk of, rupturing a pulmonary artery, right, and bleed to death. I think it's a real issue. So when I'm blowing up these balloons, when we check these balloons, we go slow, and if I feel resistance, I stop blowing up the balloon. I should be watching it on monitor. If I look up and I see that it's wedged with that much air instead of that much air, if it's wedged with a half a cc, then I'm done. That's all I need to accomplish from that. Over wedging it is the problem, right? We can do that. The stuff that we put together. So the biggest mistake I've seen routinely over and over again, and they only see it because I'm putting it together for them at the last minute. They call and they say, we're getting a Swan from the cath lab. Get our stuff ready, right? Don't wait until the patient gets here and you're trying to take care of the sickest patient in St. Johns County at the same time that you're hooking up equipment, because the equipment's not going to get put together because it's put together because it just isn't a priority now. So get your stuff ready to before they come. If they show up and you're not ready, then be thinking, well, I don't know when the last time they flushed these lines are. I need to run some saline through it, because they don't always do that in the cath lab. They come to you and those things are clotted off. It sucks. So the only place that comes, sorry, with the setup, the pressure setup together, is the open heart OR. The cath lab doesn't even maintain the triple setup. They don't even keep it there. They couldn't do it if they wanted to. So get it ready as soon as you hear they're coming. Have somebody get it ready for you if you have to give a report on another patient. Whatever, get it done. So I get if the patient's going to be putting the catheter in the unit, then I need a sheath, an introducer. This itself is flexible, it's not going to do the job. So you'll need an introducer. It's the information on the catheter right here. So it tells you what the size of the catheter is, which is 8 French for this one, and the introducer needs to be 9 French. You can squeeze an 8.5 in, wouldn't do it. Go with a 9 French, and it won't give you any trouble. You end up with an extra port too, because the sheath has its own port. So then when the physician comes, we're going to have this ready. We're going to have that ready. We're going to have this guy right here, right? That's the big hot one. That one measures the temperature as it goes by. Information gets translated between the mind ray and Edwards hemisphere. You got three things. EKGs on the bottom, and then up one on MAP, and CVP. So if I go in and I look at my SVR and my SVR is way out of whack, then these may be switched. Somebody switched those. So that's the only 2 things that can switch. EKG only fits in one spot. This is the exact same platform used in open heart recovery. So you can go get one. It's the exact same one. Ours is just on a stand. I've got my 3-way setup. Pressure bag at the top and 3 pressure lines. I have an A line. If that's all you saw here, if that's all I had was an A line, you would have no trouble setting up an A line, right? None. So think about it that way. You have an A line, And then you do the exact same thing with you do with the CVP, and you do the exact same thing what you do with the PA. Those are all exactly the same, just different labels. I have 3 other things for mind ray, right? So you know you got your T1. The T1 has the first pressure line. That's usually arterial blood pressure in the T1. You need to add this one, right? So that can be CVP or PA and CVP. You just have to know what the label is when you get on mind, right? And the way I check to make sure that I'm in the right place is I usually pull up mine and I'll say, there's my PA, and I will turn it to off. So when I watch the one go flatline on the monitor, that's the one I just turn. If I've got the PA in my hand and it doesn't say PA, I will change the label. Okay, I'll change the label. And then I'll do the same thing with the CVP. I'll turn it. Bam. I see a flat line. If it says CVP, I've got the right one. I got my Swan, obviously, and the EV1000, or we call it the EV1000. This is a mind ray box that translates the information. It's blue. This is blue. And this is what fits into those 3 cables in the back. Right? This is the other end of these 3 cables. And this goes into mind ray. If Dr. Adwin were with you and you're putting it in, he's gonna put in the first 40 centimeters, and that's when you hit the RA. Right, so you're here and you hit the RA, and so he's gonna say, all right, blow up the balloon, and you'll do that, right? You'll blow up the balloon, you'll lock it down. Let me show you the other way. The way that it's gonna be the 50% no resistance, 75% no resistance, all the way no resistance, and then you lock it down. Because if the moment you have anything wedged up on the screen, on your mind ray screen, or the moment you have significant resistance, you stop, because that's how you rupture pulmonary arteries. Anytime we're doing it, that's the way we roll. Even though honestly, it's unlikely that since we've just put that in the subclavian or whatever, that it's IJ, this guy. Right? It's unlikely that it's going to pop a pulmonary artery there. So we got that. Now it's in the RA. Right? It's in the RA, and the blood flow is starting to take it. Right? The blood flow is starting to take it. It'll take it from the RA into the LV. Across the LV into the PA, and then it'll keep going until it plugs the hole. And when it's plugging the hole, that's called wedged, right? Once it plugged the hole, now you're not seeing any blood flow back here. It's blocked off. All you're seeing is the pressure on the other side of the balloon. There's nothing getting by, giving us the indirect pressures of the left ventricle. You'll watch it look like this on the monitor. So that's a CVP signal, right? So it looks like a normal CVP. And then when we cross into the RV, we've got a nice RV waveform. When it crosses into the PA, you'll know, because now you've lost 10 off of your diastolic. So your PA diastolic loses 10. Then I keep going, and now I've got a wedged pressure. Wedged pressure, the doctor will tell you, okay, let the balloon down. And you'll let the balloon down. He'll pull back just a little bit if he doesn't want to over wedge, and then we'll get our numbers. Okay? On the screen, you'll tap, pulmonary artery wedge pressure. The screen will come up and follow his directions. Usually, if we're doing them, then we want to change the first thing we want to do is change the range, the scale, so that the PA pressures aren't 0 to 30, because we're doing this because we expect it to be high. So we change that to like 0 to 50 or 0 to 60. That way we can see the full extent of the PA pressures. And then when he says wedge it, 50% no resistance, 100% no resistance, and it's wedged. We watched it wedged. He's going to watch that for a whole screen because he wants to see this waveform of breathing pattern, the breathing pattern. And when he gets a whole screen, he'll say freeze, and there is a button that says freeze. You hit the freeze. That'll give you an opportunity to adjust the scale up and down because whether they have positive airway pressure or not depends on what is the pulmonary artery wedge pressure. Okay. The other things important about a Swan, we've had the sleeve we locked down. Important about the Swan, pulmonary. If we look from left to right to left, my pulmonary artery pulsatility index, my PAPI score. So your pulmonary artery systolic minus your pulmonary artery diastolic divided by CVP gives you PAPI score. If your PAPI, pulmonary artery pulsatility index, is less than 1, that is indicative of right-sided heart failure. So if you have right-sided heart failure, Impellas won't help you, right? Because that's left-sided. So right-sided heart failure, there are not as great options, but there are some. And then if we've got this, the Swan all the way in and wedged or whatever, we can check a mixed venous gas. We check a venous gas off the tip of this catheter. That's the last spot of unoxygenated blood before it goes into the lungs. So I take that, and if my SVO2, my saturated venous oxygen, is less than 50, that tells me I probably should check a hemoglobin because all the oxygen, so much of the oxygen is getting used up before it gets back there. So it should be 50, 60, 70. Otherwise, it's too slow. Maybe it's an inotrope, maybe it's blood, maybe we need to increase our Impella support. But it's not enough to sustain life. So we have that. We have left ventricular end-diastolic pressure, which they call it the cath lab. Here we call it a wedge. The papillary the wedge pressure is a good indicator of whether somebody can tolerate revascularization or treatment. So if their wedge pressure is high, if it's 15, 17, 18, we can diurese them. 20, 21, 22, 23, the likelihood of mortality goes up quite a bit with any procedure. So you've got to diurese them. If it's just a weak heart, sometimes we can use some dobutamine to give it a better squeeze. Open heart recovery, we'll use low dose epi, really low dose, 1, 2 mics to give it a little extra squeeze. If it's left ventricle is doing poorly, your wedge is high, your SVR is also high, then you can start some milrinone. Milrinone gives you that inotrope, gives you a better squeeze, and it also gives you afterload reduction. Right? So if you can decrease the afterload by itself, like if somebody had an afterload, an SVR of 2,000 and I gave them nitroglycerin and that relaxed way out, you would have your SVR would drop from 2,000 to 800 and your index would drop from 1.5 to 3 because it doesn't have the resistance, right? If someone is dehydrated, you get some of the same kind of numbers. So dehydrated, the aorta will just clamp down, right, to accommodate for what it has. So if you give somebody, they're clamped down, their SVR is 1,800, right, and their index is poor because of it, you give them fluids, it fills that up, fills that tank, it relaxes, your SVR again will drop to 850 or 1,000, and your cardiac index will go back to 2.5. Anything less than an index of less than, or anything a 2.2 or better is considered acceptable for a cardiac index. Yeah, and that's how I take care of people. Ask me some questions. It's fun.